Hello there. We want to bless God for your life as I welcome you to another episode of The Citizen on Dove Television. My name is Mike Adekunle. We want to say very special thanks to all of you who have been making contributions to this program, ensuring that we move forward and we do better than what we are doing. Thank you so much. We can't even be mentioning names right now. Some of you are very mind-blowing at your contributions and prayers towards us as concerning this program. But we say thank you, and we do really appreciate what you are, doing for us. Thank you so much. Some of your messages who are peculiar to our programs, at due time, we are going to be reading them out and making sure that they are all taken care of by some of our guests that we bring on the program. On this episode, we are going to be looking away from what we've been discussing. It's not going to be all politics and politics, but then today we want to look at the health sector as concerning Nigeria. So we just want to pick an aspect of it, and discuss, as I have a wonderful doctor here with me in the studio. So I'd like you all to please sit back and learn from what we're about to discuss today as concerning health and health delivery in Nigeria. We want to look at the case of infertility in Nigeria. How serious is the case of infertility in Nigeria, both in men and in women alike? So this we are going to be looking at, and many other things surrounding this aspect of infertility are what we are going to be looking at today. So my guest in the studio is, I love to call him Dr. Engineer, but then we have to pick one today. He will tell us the engineering part of being a doctor. And I told him that there is human engineering. Maybe he will lead us into that. So I have with me the Managing Director and Chief Executive Officer, the CEO of ROA Specialist Hospital here in Arepo, Ogun State, Nigeria. A place people usually call ROA Specialist Hospital, so that some of you who know it to be ROA can easily associate with it. It's actually ROA Specialist Hospital, but popularly known as ROA. So the MD and CEO is here with me today. Dr. Abiola Ajayi is here in the studio. Good to have you, Dr. Ajayi.
Thanks for having me. It's my
Thank
pleasure.
you so much for your time with us.
My pleasure.
We really appreciate you.
My pleasure.
Thank you. All right, so tell us, doctor, engineer, so what's the relationship? At what time were you a doctor, and at what time were you an engineer, and at what time did you become a doctor?
Interestingly enough, for my type of brain, where my brain works, the two are really similar.
Okay.
Engineering involves systems, just like the body involves systems. So if I'm trying to design a plumbing system, I know I need a pump, I need pipes, I need an outlet, and I need maybe a release valve for excess pressure. Human bodies is similar. We have heart, which is our pump. We have blood vessels, which are our pipes. We have release valves, which are strokes and heart attacks. So it all makes very, very good sense to me, at least. Yes.
They are still the same altogether. So you went on to study engineering before coming back to studying medicine.
I was accepted into a accelerated medical program out of high school, what they call high school in the U.S. So at age 17, I started college. I got my BS, my first degree in 2 years. And then I started med school, the 2 years of med school. I left when my parents came to Nigeria. They did not want me to do the engineering program since I'd already started medicine. It was a pretty prestigious medical program. So one time they left, on the trip, their yearly trip, and I went to the office and I went on a leave of absence. I withdrew and I went and enrolled into engineering school because I had taken some loans and I had some money left over. So I did that about 18 months, got my master's in engineering. My father didn't talk to me much during that 18 months until I went back to medical school.
So he wanted you to become, a doctor.
And he's not used to people stopping in the middle and finishing. And to be honest, that's one of the first miracles God performed. So I was able to get back into another medical school and finish, because it took me about 18 to 19 months to get the engineering degree. So and I now finished medicine.
What's your area of specialization right now as a doctor?
I like to say we're not really limited at ROA. I primarily practice urology and gynecology, what they call urogynecology. But the amount of what I would say primary care, which is internal medicine, family practice, that's at least half of my patient population. And I also practice something called integrative medicine, which is trying to find the root cause of the medical problem. Instead of just, you have a headache, somebody just says paracetamol. You have typhoid, somebody says go and get this drug. Instead of looking at why did the person get typhoid, why do they have a headache? And oftentimes it's lifestyle, nutrition, or something else that you point to. So I practice all of those.
You practice here in Nigeria and you have your outfit here in Nigeria. What made you leave the States, overseas, USA precisely?
Yeah,
Coming down here to...
I was in Miami. We talked about a little bit of this off camera, but my mother tricked me. And thank God she tricked me. I'm enjoying my life now.
Wow, so you enjoyed the trick, right?
I didn't enjoy it then, but I definitely enjoy it now. She asked me that before I started my medical practice in Miami, Florida. She said, come with me to Nigeria for 2 weeks and I'll buy your ticket. Let's just, relax some before because when will you ever have a chance for a vacation again? I said, okay. So I went, and it had been over maybe 10 to 15 years since I'd been in Nigeria before.
Okay.
And straight from the airport, she took me to Banana Island. Stayed there, I'm looking around like, this Nigeria is amazing. Took me to some other rich people's homes. I saw Nuga's home with a big bull in front. I said, Nigerians are, I saw Mercedes, Porsche going by. I said, wow, this place is really, has really changed. It's not bad, it's a good vacation. So around the last day, she now brought me to Arepo. And then Arepo was all bush. So as we're driving in, I started getting a little bit worried because I couldn't see out of the car. All the bushes were higher than the window as we're driving in. I said, Mama, where is this jungle that you've taken me to? I didn't know we were going on safari. And she said, no, your father owns some land here, and he wants to put a hospital. And he wants to be able to use the hospital for medical missions. And he had been doing medical missions in Edo State. That's my home state. So he wanted to have something here close to Lagos where they could come and do medical missions. And he said one nurse was going to come and do this and that. And I looked at her. I said, I'm not going to do it well. I will supervise the building, and then I'll leave as soon as it's done and go start my own life. And if you know how much energy I put into it, because that's where engineering also helped. So I'm checking the electrical outlets. I am, I have a multimeter. I walk around with a multimeter, all my tools, watching the technicians, making sure they don't put pipes that are leaking in the wall, all those kind of things. I caught so many things that we improved on. So after going through all that effort, it felt like leaving a newborn baby behind. And I just said that, okay, let me just supervise the first surgery. Because let's just make sure we can do surgery, since when Dad comes over, he just comes over for 2 weeks to do a medical mission. Then I said, there's a lot of people with eye issues. Let's just start an eye center. We do cataract surgery. I said, there's need for dental. We started dental. Now I have a diagnostic lab opening next month. Wow. We've done almost every type of surgery there besides open heart surgery. And sometimes during our annual medical missions, which we did many of them, at least once or twice a year before COVID, we do 70, 75 surgeries in just a few weeks. Wow. And people will come from all over, and they're not paying. There's no payment. Whatever surgeries we can do for them, we do for them. I'll just line them up, and sometimes we do 3 to 4 surgeries at a time, and just operate it from morning to night. People will come from the U.S. We mix with AMPA, the Nigerian Physicians Association, and really have a good time solving people's problems.
Lovely. We can only say well done. But then I heard an information, or like a testimony of your hospital. Over 10 years now, there had not been any record of death in surgery.
Yeah, no intraoperative.
So what was his secret?
There's only one secret. He lives upstairs. It's God that does that. The part that I play is carefully choosing who goes to surgery and who doesn't go to surgery. What I used to tell my staff, not all money is good money. A lot of doctors, maybe because of financial constraints, they're forced to, they accept surgeries that don't have a good outcome or may not have a good outcome. Oftentimes, maybe because they want to put the money in the bank. I've had an MD of another hospital tell me that he has a morgue attached to the hospital, so that if I don't get them coming in, I'll get them coming out. And you understand the implication of that. That made me rather uncomfortable, So I quickly left that meeting, and I said I want to dedicate energy into not having that kind of reputation,
But to saving lives.
but to saving lives and not wasting any lives, right? So sometimes if a case looks too difficult, doesn't look positive, I'll try and find them help elsewhere. I'm also the vice president of the Nigerian American Medical Foundation, and they connect doctors in the diaspora with patients in Nigeria. So sometimes I do that, but the cases that we keep, I try to make sure that one, sometimes you see people in Nigeria doing surgery, no blood, no blood backup, you know? Sometimes you see them doing it with no monitors, no blood pressure monitors, no, so all of that stuff, that's where engineering also helps. All of those things are set in place.
So that speaks to the fact that some who are dying during surgeries are not necessary. Some of them probably might not necessarily need to die,
They're
but for
unnecessary.
carelessness of the doctors.
Unnecessary deaths.
Wow.
I've had a consultant, of course I won't name names, but a consultant come to do surgery in our place. I had my technician, I said, put on the blood pressure monitor, the SpO2 monitor. He just smacked the head. We don't need that. This case is not that serious. I said, sorry, sir. Every case we do here is serious.
It's serious.
So
You
every
must
case
follow
we're going to
every
monitor
procedure.
the patient. It just takes 5 minutes. We make sure we have oxygen on ground at all times, you know. Make sure I have trained staff ready. So it's careful planning. The most important thing I do is keep that place running, do some diagnosis, but make sure that, you know, we don't waste any lives.
Wow. There's this question that I believe might be in the mind of most people, including mine. Why is it that doctors will see that this case is almost negative, that this case, probably this person is going to die, and yet they will still request for money? Go and bring so amount. Probably, maybe on your way to getting the money, you just hear the news, oh, sorry, it's gone. Or probably at the depositing of the money, you say, oh, sorry, and the money is gone.
It's multifactorial. There's some doctors that are maybe in an environment where there are not a lot of medical professionals, so they have to take every case because the people don't have a choice. So I don't want to paint everybody with the same brush. And there's some, you know, doctors that are not men of God that don't mind if all they care about is that money entering the account. So both things can be true.
You don't like money.
Well, and anytime somebody tells me that, I say I absolutely love money.
Oh, you really?
I absolutely
love money. But you know the Bible says the love of money is the...
Well, I mean it kind of jokingly, but not that, because usually when somebody's telling me don't love money, they're maybe not wanting to pay. I said, no, I have 76 employees. I need to pay their salaries. But the way I generate money is concentrating on patient outcome. So my main focus is let that patient leave happily. You know, let that patient, whatever sickness they came for, we've treated that sickness, and then everything else will come.
Let's go into the crux of the matter. How serious is the case of infertility in Nigeria?
Fertility is very serious. It affects, in some areas of Nigeria, 30% of families or couples are affected by infertility. And the national average in Nigeria is about 25% of couples. So that's 1 in every 4 couples will experience infertility. And when you're looking at infertility, you look at male factor, that's about 40% of the time. Female factor, meaning there's something wrong with the woman, 40% of the time. Leaving 20% of the time, or 1 in every 5, both parties may have an issue to take care of. So it's quite prevalent. It now represents almost half of my practice, which that has changed over the last few years. And I'll tell you the truth. Sometimes when I have a lady that's been trying to get pregnant and she now comes in with that positive pregnancy test, now I stand up and we dance. We shut the door, we dance, we say a little prayer because it makes me happy. You know, I had a lady last week, 3 years looking for a pregnancy. She's finally pregnant. I had to dance. She had to dance. Those kind of things, those kind of results make me very, very happy.
Primarily, who is to be blamed? Because in this part of the world, we tend to blame the woman. In fact, in some culture, they will have to send their packing that you are the cause. But tell us the truth.
99% of the time somebody sits across from me and talks about infertility is the woman, and she's by herself. And I now have to repeat the statistics of 40-40. And I will not take an infertility case if the man will not come in and at least do a sperm test or a semen test. But it's very common in our culture to say it's the woman, it's the woman. But a lot of times I find that azoospermia, a man has no sperm, or a very, very low sperm count, or some other issue, and it's equal. It's equal in terms of prevalence in both sex. So it's not fair what we do, and I hope that with these kind of discussions, those things will slowly start to change.
Okay, so now where should we pick it from? Let's speak to causes. What are the possible causes of infertility? And at what time, as a man, at what time should I start to check whether I'm going to be fertile when I get married or not? At what time should I start checking that? And as a woman, at what time should you start saying, okay, will I be fertile when I get into marriage? You get what I'm trying to say right now. So let's look at this area.
Yeah, for the causes, I'll focus on, because I could talk all day about causes, but the ones that are very common here are, for women, we have tubal issues, mainly the fallopian tubes. You have two ovaries that carry eggs through fallopian tubes to the womb or the uterus, and blocked tubes mean the eggs will never get to where they're going. I see that very common, as well as something called PID, pelvic inflammatory disease, like we used to call it toilet infections. So women that have infections there can also have infertility issues. And then we have hormonal causes, some things like PCOS or polycystic ovarian syndrome. That is also quite common in Nigeria. And for men, it's either sperm production or sperm quality. So, and then they can also have hormonal issues, low testosterone, high prolactin, those kinds of things. Those are the ones I see most commonly. And they can also have blockages in the tubes that carry sperm from the testicle to the prostate.
Okay. Let's pick it one after the other. Let's look at the women's side right now. Now, if a woman is having a blocked tube, or not having, maybe having ovarian cysts or having infections in the, cervical region or what have you. Now, what could cause all this? And how can all these things be avoided?
Great question. The number one cause is poorly treated or untreated infections.
Okay.
So these are, when a woman will have vaginal discharge or sexually transmitted diseases and they're not treated on time, or they're poorly treated, meaning they didn't use the medication for long enough. That's the number one cause of blocked tubes. And it's painful when we do a test called HSG to look and see those tubes are open. And when it comes back, both tubes are blocked. It's painful because now you start counseling that you may need IVF, which we know runs in the millions of naira.
Okay, when those two tubes are blocked, no solution?
There's solutions. There's a procedure that I do a lot now called hydrotubation, which it used to be a little controversial, but it's done in the theater under sedation, where I try to actually force those tubes open with a combination of different fluids and drugs. And we've been successful. About at least 40% of the women we've attempted in the last 1 year have opened at least one tube. So, and it's truly not a surgical procedure because I'm not making any incisions. I'm doing everything through the cervix.
Okay.
But you can also do full surgery, what we call laparotomy. You open and try to fix the tubes yourself. Women can also have adhesions, especially if you've had surgery before. Adhesions can also help block tubes, so you may have to do that through an opening in the belly.
Okay. You were trying to say something earlier before I interrupted you, as concerning solutions to some of these things.
Yeah. So some women, it's just hormonal. They have hormonal imbalances.
Yes.
Some women have high prolactin. Some women have low FSH, LH. All of these terms, it's follicle-stimulating hormone, luteinizing hormone. They're just part of the woman's menstrual and ovulation cycle.
Okay.
And women will know if they may fit in these categories if they have unexplained nipple discharge, especially milky nipple discharge. I see that a lot.
Okay.
That's usually associated with headaches, or
So it's not normal when a lady is seeing that, like breast discharge, like having a fluid coming out of the breast.
Yes. No.
While you are not breastfeeding.
While you're not,
child.
you're not actively. You didn't have a child within the last year, so it's definitely not normal, and it's one of the more common ones that we see, and it's rather simple. Once you've identified it, for me now, I use half a tablet a day of the particular drug, Monday, Wednesday, Friday, for the woman. Within a month, we've corrected that particular issue. And if she doesn't have blocked tubes and her husband doesn't have a low sperm count, most of those women get pregnant rather quickly, within 3 months.
Does any of these causes, lifestyle related, maybe lifestyle, the kind of work a woman is doing, or exposure?
Yeah.
Does any of these have effects on?
Very, very true. Lifestyle can affect. If you have a lifestyle where you have multiple sexual partners, and that's one of the causes, because it leads to sexually transmitted infections and sexually transmitted diseases. That is definitely occupational exposure. If you're working around, for example, farmers working around what they call organophosphates or pesticides, have higher degrees of infertility than the general public. And those working in factories where they're exposed to different chemicals, like dyes, chemicals that are used to dye fabrics and things like that. Some of them are quite caustic and could cause infertility. And then you always have to look at air pollution. Air pollution is part of it. Anything that can damage your DNA is part of it. People living in the Delta region, Niger Delta region, there's over 1 million people exposed to poor air and poor water quality, and there's a lot higher rates of infertility in those regions than other regions. So there's no way to avoid. Long distance drivers, truck drivers that drive for a long time, the scrotal temperature gets so hot that it basically kills the sperm, so they often have low sperm count. So
let's now speak to the side of men right now. You are now trying to mention some certain things. So let's look at some major causes as regarding men, having cases of infertility, all right? So what are the causes with men? You just mentioned a high level of heat to the scrotum. Okay,
so men too. Men can also have infections because the sperm are made in the testicle, and they have to take some tubes to the prostate before leaving the body through the urethra. So men can have obstructions and blockages in those tubes as well, just like women can have blockages in the tubes. And what I often see is either poor sperm production or poor sperm quality in men, and sometimes it's diet, poor diet, malnutrition. People that are obese or diabetic can also have issues with infertility. The rate of people that have erectile dysfunction is extremely high in those that have high blood pressure and diabetes. If you have erectile dysfunction, it's going to be hard for you to get someone pregnant, isn't it? So we do see that a lot in my practice.
What are the causes to some of these things, especially like you mentioned now, erectile dysfunction? And what are the avoidable pitfalls that one can, easily pick at?
I can only speak from experience, right?
Okay.
But the younger ones, the level of unprotected premarital sex that's not meant for procreation is on the rise. So the sexual transmitted diseases are also on the rise. Okay. For men as well, there's a epidemic that's starting now with drug use in Nigeria. Before, when I used to come, I was born in Nigeria. I just left when I was 6 months old, and we used to come on vacation of trial every year, every other year. I never heard of anybody using drugs during those times, like hard drugs, like methamphetamine and cocaine and all of that. But all of those things are here now. I had a patient yesterday with smoking something called ice. And I said, there's ice in Nigeria? That's a heavy methamphetamine. People will not sleep for 3-4 days. That kind of thing. So drug use, excessive alcohol use, smoking, even all of those things can affect sperm, and even marijuana use. All of those can affect your testosterone, affects your erections, affects your sperm quality and sperm production. So that's, for men, those are the main things that I see.
So what are the herbs that are available for them, for people living with such?
I'd like to be a holistic doctor, so if I diagnose you with infertility and I look at maybe for the man has a low sperm count, I'll start asking questions. I first tell them that, hey, I was raised in the U.S. I just came here relatively recently for my age. There's nothing you should not be able to tell me about. I start like that. So if you use any drug or how you use alcohol, just tell me the truth so I can actually help you. And oftentimes that breaks the ice and people come clean. So, I mean, I've put people in rehab before. I've done rehab for them in my hospital or detox.
Okay.
I've arranged for psychiatric counseling. I try and do it all. Whatever got them to that place, I will try and help them out of it. Often, sometimes I prescribe meditation
Okay.
for different diseases. Not as much for infertility, but if a person is stressed, under constant stress all the time, that can cause infertility, and it can cause infertility in men or in women. So if I feel like that person, that's their main issue, oftentimes they cannot change what's causing them stress. Maybe it's the job, and they can't change their job at that time. Maybe it's a family issue or whatnot. But you can always change your response to stress, and that's what I try and focus on. You can always change how you accommodate or accept stress and how you deal with it.
Okay.
And so that's when I now start talking about things like meditation, yoga, prayer, stretching, even breathing exercises. You asked off air, you asked about AI.
Yeah.
And I use AI every day to help speed up, like I've programmed my own AI API.
Okay.
My first master's is information architecture and knowledge management, so a lot of computer programming. And so I program my own API so that I can do customized plans based on what I believe in as a doctor, customized plans for different patients. And it will be nutrition-based, lifestyle-based, even diet-based. All of those things help.
Oh, wow. And how has the result been over time?
Really, it's stunning. I've started tracking statistics for these last 2 years on basically those lifestyle plans.
Okay.
I've had, we mentioned PCOS, polycystic ovarian syndrome, very common in women in Nigeria. Okay. And I have some of them on social media. I hope some people will go and see. We have testimonials from women there's a woman there who has twins now. The main thing I did was change her diet.
Wow.
And she had been looking for children for about 3 years. And she's on there giving testimony. There's a lot of them. I can treat PCOS with medication or diet or both, but we underestimate how much diet plays a role in disease processes.
To what extent can infertility go in a life, say man or woman right now, to say, okay, someone can say, oh, I've given up, that I'm not going to have a child again, because for this case that persisted, is there, how do I put it now? Let me put it this way. Can we say no hope at all at a point? At what point should we say there is no hope for someone to be fertile?
I've learned to never say that in Nigeria. Number one, I've witnessed miracles myself in front of me. So
as a doctor, you believe in miracles?
I do. I definitely do. My life is a miracle. Me being here is a miracle. I definitely believe in miracles. So I rarely get to the point where I say there's no hope at all. I try to exhaust every option. If I was in the U.S. and I have a woman approach me last month, 49 years old, wants to try, her still having menstrual cycles, wants to try and get pregnant. And I said, I'll try, I'll help. If I was in the U.S., I wouldn't have taken that case. It's very, very different across the ocean because of the cultural stigma. She desperately wants. She says she's never had a child. I've had women that bleed so much from fibroids that really need to have the womb removed, but they will not have the womb removed because they want to somehow have a child in future. And fibers grow back, so when you remove them, they can grow back. So I try not to say no hope. Probably the condition that has the least hope is something called non-obstructive azoospermia. It's when a man, or associated primary testicular failure, meaning the testes just don't make sperm. And if somebody has a low sperm count, I can tell you 20 things to do to try and increase the sperm count. But if somebody has no sperm, zero sperm count, then there's a lot less hope for those. Usually we try and do surgery to try and free the place. But if I go to the testicle and take a sample called testicular biopsy, and I don't see any sperm there, then we start having issues. So we now start talking about sperm donors and things like that. But there's always hope to have a child.
Okay, I love that. There's always a hope. You speak like a pastor. That is very good by me.
And my uncle's a pastor at this place. He wants me to be a pastor. I said,
really?
I'm not ready yet.
You are already. You are pastoring. There are people you are pastoring right now. Even as we are speaking right now, people are being blessed by what you are saying.
Amen.
We are not all going to be on the pulpit.
Amen.
Then, you know.
Amen.
All right, so we are still going to be looking at cases around IVF, surrogacy, and all that, and in relation to our culture, you know, when we come after this break, okay? All right, so we are going on a very short break. We shall be back to continue on this particular subject of infertility. Stay with us. Welcome to a platform for a robust, inspiring, and engaging conversation in the world of politics and governance, business, education, and more, and concerning you as a citizen and your civic responsibilities. Watch The Citizen on Dove Television at 1 p.m. every Tuesday, West African time, and a repeat broadcast every Thursday at 11 p.m. The Citizen, we are all in this together. All right, you're welcome back from that short break. I'm still with Dr. Ajayi, Dr. Abiola Ajayi, the MD CEO of ROA Specialist Hospital here in Arepo, Ogun State, Nigeria. We've been looking at the case of infertility in Nigeria, and thank God, like before we went on the break, he speaks like a pastor, and I love that. He's kind of instilling hope in everyone. There is hope. I've asked you of how serious is this case in Nigeria, and the way you have put it had not raised a very serious alarm, but then
It's very serious.
It's very serious,
No,
because
very
it's
serious.
those who are living with infertility can really tell. You know, you talked earlier about stigmatization. You know, it's a serious case. So
There's even a, I don't know if I'd say philosophy or a drive. Now, I didn't know until some of my nurses, I saw a couple of nurses went through this, where the family of the boy said that unless you get pregnant, we're not going through with the wedding.
oh yeah, trying to like say you must give us evidence of you being fertile before we proceed
Before
into
we proceed
marriage.
with the marriage. And
Wow.
I didn't, no, I had to call my mom that night and say, is this true? She said, yeah, in some
Yeah, some people do.
cases.
Yes.
So that's a lot of pressure. you
So
know.
I asked you earlier, so as a young guy, as a young lady, how would you know initially, before going into marriage, that you are going to be fertile in marriage?
So I have some people come now that ask that question. Some couples will come, and you know, for the man, I'm going to do a sperm analysis, look at the sperm count, look at how many normal sperm he has, how active those sperm are, look at his testosterone level and another hormone called prolactin, and I can give a fair assessment that, hey, you're good to go, 90%, 100%, or just try and give people some positive odds. And for women, we go a little bit deeper. We do hormone profiles. There's even a test that can give us the fecundability score, meaning how fertile is this woman, because that's really important for women especially, because they're born with all the eggs. So when a woman is born, she's born with all the eggs she's going to ever have. And she loses eggs every month until they're none.
As she observes her,
her,
cycle.
her menstrual and ovulation cycle. So the older, as the older you get as a woman, it's for both men and women, but for women especially, it's much harder to get pregnant. So there's a way to give a probability of getting pregnant with a few different blood tests.
Okay, what's your opinion around surrogacy, like trying to bring sperm or bring egg from one donor to another to infuse in a lady, and also IVF, which you call
in vitro fertilization.
In vitro, okay, that's the language, but it's commonly known as IVF.
IVF,
so,
yeah.
Now, so please walk us around.
I've been involved in a few of those cases. There's a doctor in Magodo that runs a fertility center, but he'll send me the men. So I prep the men, low sperm count, poor sperm motility, and then he'll prep the women. And sometimes I've had to arrange for a surrogate, had to bring a lawyer in because you need to have all your legal documents there. You have to do a lot of counseling because sometimes the surrogate gets attached to the fetus, right? The baby, and it's painful to carry something for 9-10 months, and then now it's just ripped away from you. Some women abscond; they disappear, and even sadly, there's some exploitation of low-income women, especially from the interior, where They're not really paid adequately
Is
or
it a
treated well.
process that should be encouraged at all? Does it worth the stress?
For me personally, they're not my favorite cases.
Okay.
Because when somebody goes through IVF, they've spent millions, maybe they've sold land or their car or something to do it, and it fails. The first time one of my IVF patients went through, I cried.
Wow.
I cried. I still remember her name. I won't mention it, but I cried. It was painful because I so much wanted her to get pregnant, and I knew how much time they had gone through, what trouble they had gone through to try and have that child. So it's there are a lot of different factors that play. I'll still help. I'll still do my best, but sometimes they can be tough, challenging.
Wow. Do you believe, and all these things you believe are possible with God? So at what length should a couple say, let's go for surrogacy, let's go for IVF?
If first of all, infertility, the textbook definition of infertility is unprotected sex 3 times a week at least for 1 full year, right?
Okay.
And so after a year of trying, then you should go and seek professional help. But what I've changed to in Nigeria is that whenever the couple comes and asks me these questions like, hey, we've been trying for 4 months and we're not, I'll start because of the stigma.
Okay.
I won't turn them away. Hey, come back in 8 months. I don't do that. If you've been trying what do you call ART or assisted reproductive treatments, where maybe you're getting hormone shots or you're on something to boost sperm, and you've tried that for a year, and still no issue, as we say in Nigeria, then I would now say probably go to the next step. If you're above the age of 35, then I cut everything to 6 months, six months, because we don't have as much time then. But a year is a good place to start.
At what age is good for a lady to say, I want to go to marry? I mean, I'm going into marriage as a lady for productivity's sake. At what age would you advise? Because, in Yoruba, they say, Ile obìnrin kì í pẹ́ ṣú. That is, a ladies wrap up productive years earlier than,
very
than
true.
men. So, what's your advice?
Very true. Well, I'll always talk about statistics. I like statistics. So a woman's reproductive health drops significantly from 35, age 35, right? So the best years are those 18 to 25. Those are your best reproductive years as a woman. Not telling anybody when to have their child or
Sure.
not, but those are probably the best years. Her menstrual cycle is solid. It's how would I say? It's routine. It's predictable. Menstrual cycle predictable, and that's usually when they're most fertile. And after age 35, it gets much harder. And after age 40, it even gets more significantly harder. So I would tell people to try and wrap up everything if they can, by the time they're 35.
Okay.
But sometimes it takes people a while to find their partner, their mate.
Of course, somebody at 35 still believing God for a life partner.
So, and a woman the average woman will go into menopause where the menses will cease between the ages of 45 and 55. So, if you've not wrapped up everything by 45, then it may be almost impossible.
All right, since you mentioned this menopause issue right now, though that's not the core of our discussion, but just a side attraction. Now, a lady who is going into menopause and having continuous discharge of blood, what do you have to say around that? What's the cause?
Okay, so menopause means the meno is Latin for menses, right? Okay. So pause of menses, meaning menses has stopped. So if that woman is still bleeding from the vagina, that's now called dysfunctional uterine bleeding, and it needs to be investigated quickly because some of the causes are cancer, whether it's cervical cancer or endometrial cancer, and there's high levels of cervical cancer in Nigeria, even high levels of endometrial cancer. Endometrium is in the uterus or in the womb. High levels of those cancers, and both of those cancers are difficult to deal with because you catch them late. So by the time you're seeing all that bleeding, a lot of them cancer has spread to different parts of the body, and then the prognosis is a lot more difficult. But if you've gone through menopause and you're still bleeding, you need to quickly get that checked out.
What about the continuous bleeding around menstrual period, like you are not at the menopause yet, but your menstruation probably should be around 3-4 days, and you are seeing it 7 days, blood is still coming out.
Yeah, so you can have something called dysmenorrhea, which is painful menses, excessively painful. You can have something called menorrhagia, something called metorrhagia. Both of those mean that your menses may be longer
Yeah.
than usual, than it's supposed to be, or irregular. So the average woman is supposed to menstruate every 28 days. It's supposed to be able to set your clock to it almost.
Okay.
And when you start seeing people go from 21 days to 30 days or have these wide varieties, they may have other issues. So I usually find out that those are hormonal issues, or they have fibroids, or they may have the things I mentioned before, cancers even.
Okay. Okay. Does fibroid have anything to do with infertility
Definitely.
in a woman?
Definitely. Definitely. One of the leading causes of infertility, because fibroids can block tubes.
Okay.
Right? Fibroids are physical growths, right? They're rather dense. If I would describe it, if I don't know if you know a tennis ball, what a tennis ball feels. They're at least that dense or more dense. So they can block tubes, they can block cervical openings.
What is this issue with fibroid? Because somebody made an assertion, I don't know, I'm not a woman. Somebody made an assertion that every lady has fibroid.
Sometimes it feels that way. When I'm
really?
doing ultrasounds, I would say at least 40 to 50% of women I scan will have at least one fibroid. But I'm scanning a lot of women that are already having infertility issues or bleeding issues. I'm not scanning normal women often, but we don't know what causes fibroids, and we just know that in Black community is higher, and this could be a significant cause of infertility. You know, the Black Americans also have higher degrees of fibroid than their white counterparts.
Okay.
And you know, a lot of the Black Americans, you know where they came from? They came from our West Coast.
Africa,
And so it's something that we have to leave that to God until he tells
So it's a
us.
Black thing.
It's a Black thing. White women get it too, but it's not as common as in the Black community.
All right, now, so let's speak to, the governmental area of infertility right now. Is there any policy or any concern from the part of the government addressing the case of, infertility?
I will never speak against the Nigerian government. Why? Because I'm a Nigerian.
Yeah.
I like to be careful also. But no, there are a lot of challenges. Doing anything in Nigeria is difficult. Logistics are very, very hard. You know, roads, power. We have so many barriers to any kind of program you want to. And the first program one of the first programs that I knew of that the Nigerian government around this fertility issue was actually too much fertility, people having too many children. So it was in 2022, a policy was brought out where they now started having an emphasis on family planning and family. Yes, exactly. But for infertility type programs, they're few and far between. Most people get infertility treated in private hospitals like my own.
Okay.
Yeah, I would say about 75% of them are at least initiating their treatment in private hospitals.
In juxtaposition, let's look at it, Nigeria, USA, where you are coming from. How is the government over there addressing the case of infertility, or is not a concern over there?
Oh, it is. It is. You know, we mentioned that in the Nigerian rate, infertility 25 to 30% in some areas, and in the U.S. is about 15% of couples will have that. The difference is that a lot of people have insurance there, so and some of their insurance will cover things like IVF.
Okay.
So they'll do 1 cycle, 2 cycle, 3 cycles of IVF before they get pregnant, and it will be covered by the insurance. You do have to pay a portion of it, but it's not like here where the whole burden is on the family. So that's the main thing. Nigeria performed about 7,000 IVF procedures over the last year across about 100 different clinics. That's not enough. You know, it's not enough access to IVF. So we need to improve, and that government hospitals need to improve. Private hospitals also need to improve.
Wow. All right. So, Dr. Ajayi, before I let you go today, it feels I've really squeezed you in a way, but it's good. You know, now that we have you around, we must make good use of your presence with us. You are the kind of person that's not always available for your, you know, your time and the kind of work you do. So really appreciate these few moments you are having with us today. But then, would you like to comment on the government of Nigeria, the state of affairs in Nigeria?
I know this is a political show, but I have some relations in different places, and my dad has always counseled me not to enter the political arena now. I do have aspirations, maybe when I get older, I wouldn't mind being a commissioner for health or
really?
just to leave a lasting legacy. I would like to do something where we improve prostate cancer screening, and I would like to have my name on that, right?
Wow.
So, and I already have an idea of a plan, how we would do it, have a mobile this from government health center to health center. I've literally written the proposal in my head, and I know that it would make a huge difference because catching prostate cancer early,
Yeah.
if you catch prostate cancer early, 99% of men may not even lose a year of life. But if you catch it late, 65% of those men, from the day of diagnosis, will be dead within 5 years.
There have been lots of campaigning right now around cervical cancer. So
Yes,
you want to raise your voice on prostate
cancer, yes.
All right. So
yes.
is it as so serious as cervical cancer?
Yeah, oh,
the
definitely.
rate?
Second leading cause of death for men, so it's definitely significant. First is things like metabolic disease, hypertension, diabetes, wrap those together. But after that is prostate cancer. 1 in every 5 to 6 men in Nigeria will develop prostate cancer in their lifetime.
Yeah.
So it's extremely significant.
How's our healthcare delivery in Nigeria? And by the time you eventually become Commissioner for Health, some people are watching us right now, probably who are governorship aspirants, and probably may want to like say, oh, this guy is brilliant, he's good. I think I would love to have him on board.
No problem.
Somebody like me would like to have you on board.
No problem. no problem.
So what would be your major advocacy around healthcare delivery in Nigeria?
Is access, really. You know, the teaching hospitals, which are, you know, our gold standard for government hospitals, they're overworked. They're overworked. They're overworked and overcrowded. So, and there are other challenges. I don't want to name the hospital by name, but there's one to the east of us here towards IB, right? They have no light. They've not had light. This has been in the news, so people may hear about it. If they have an issue with PHCN, NEPA,
yes.
They've not paid the bill or this and that is outstanding, so there's no light. So people...
And it's a government hospital?
Yes, it's a teaching hospital.
Wow.
And so oftentimes some of the patients come and bring their own small generator and put outside of their room to power. When I heard this story just like last month, I said, there's no way that's true. There's absolutely no way that's true. But I know a lot of teachers, doctors that teach there, so I called and they say, yeah, it's true. Wow. No light. No light. Wow. I don't understand. We have 24-hour light in my hospital, and I almost killed myself to make sure that happens. I don't understand how we're going to run a hospital without power, you know, without steady power. Their operating rooms have generators attached to it, but you need steady, reliable power. I was in a teaching hospital when I first came to Nigeria. I did a apprenticeship or housemanship so I could get introduced to tropical medicine. So I spent about a year in Lassuth while we were building my hospital. So I saw some things there that I said, no, I'm not going. This will not happen. This will not happen in my place. But some of the problems go deeper than you know. I worked with one hospital in this Lagos to another teaching hospital on a cancer center, and we were developing a ward for prostate cancer to do a type of therapy called brachytherapy. I've had it done. I usually have to send patients to the U.S. for that. If you have prostate cancer that's really not left the prostate, you can put radioactive pellets right into the prostate, push them into the prostate, and it kills the cancer from the inside. Wow. Those men do fantastically well with the treatment of prostate cancer. Within a few weeks, they're, you know, almost back to normal in terms of, you know, their PSA levels and things like that. something happened. The consulting company got kicked out of the thing. Maybe some financial issue between the CMD and I heard so much because I knew the CEO, I knew all of them, and so now the place is not active. And this was years. This is like at least 2-3 years ago. So that wing is still not operational. And all the Indians and South Africans that came to help, they've all left. So we just need a little bit more follow through.
Wow.
With some of our programs.
Oh, help us. I know we'll get there one day.
God will help us.
At least,
we like to say that in Nigeria, God will help us.
God will help us. It has almost become a mantra every time.
Very
God will
true.
help us. God will help us.
Very true.
As if it was God that put us in the mud, in the problem. But definitely, we still have to look up to God. A man who has nobody to look up to must look up to God.
Amen.
In Nigeria, we are kind of helpless, so to say, but then we still have to look up to God.
Yeah, we just need to dedicate more resources to some of these things. The one thing, I don't know if I should say this, but how much, okay, I don't know if you've been following what's going on in American politics with Elon Musk and the Department of Government Efficiency, DOGE, right? They're seeing that trillions upon trillions of dollars have been wasted, and they're cutting out that waste, actually. So some of that money will get put into healthcare, some will get into education. Sector. I mean, trillions of dollars they're finding. We need something like that.
We need something like that because our problem here in Nigeria is not money, but how to rightly apportion money to where it's been needed.
That's it. You can still be rich and wealthy, but no man needs more money than they can spend in 100 lifetimes. Yeah. Leave some for the other people. That's my little advice for them.
Thank you for that wonderful advice. We believe our leaders, we take some of these advices and
when you have to leave your country for medical care, you should know that's a problem.
That's a problem. That's a problem.
You should know that's a problem.
Because one of your primary responsibilities as a leader, as a governmental leader in any country, should be the
Israelis don't leave Israel for medical care. Germans don't leave Germany for medical care. Americans don't leave America for medical care.
We leave our own country to go meet them.
And we have our rich, top people are the ones that leave. The only ones that can afford it.
And what they are going to do over there, they can't domesticate it. They can't, okay, this kind of machine is somewhere in the world. Okay, I'm bringing same to Nigeria.
That's what my dad and I did. So brought in so much medical equipment just to say that we have these things in Nigeria. Others will follow, I'm very sure of it.
Dr. Abiola Ajayi, if we should continue like this, probably we might be entering into another topic of discussion entirely.
It's been my pleasure.
I most sincerely appreciate you for your time.
Thank you very much.
You've been so phenomenal.
Thank you very much.
We really appreciate you.
Thank you.
Thank you so much. All right, viewers, we really appreciate you for your time with us again. I'm sure you've learned one or two things from what we have brought to your view today. Please do well to check yourself up as regular as possible for your health. Is very, very important. This is not about government right now. It's about you. So please rise up to your own responsibility to ensuring that you take good care of yourself. God bless you. I'm Mike Adekunle. See you next time. Bye for now.